I'd like to introduce our next speaker, Emily Gutierrez. Emily Gutierrez received her associate's degree from El Centro College in 2000. She obtained her baccalaureate degree from the Texas Women's University of Dallas in 2002 and her master's from the University of Texas at Austin in 2010. In 2014, Emily graduated with her DNP from Johns Hopkins University. Emily's doctoral focus was on improving pediatric clinical management of natural health products. Emily now practices in primary care and is adjunct faculty for the Johns Hopkins School of Nursing. She is also the director of neuronutrition for the Karnick Institute, where she pursues research and evidence-based scholarship for integrative management of neuropsychiatric disorders. Please welcome Emily.
Well, hello. Thank you for attending my session, and I hope that after our hour together that you're going to walk out of here and you're going to learn a few things that you didn't know when you came in here. A lot of people ask me how I even got interested in integrative medicine, and I have to say it was by default, because I live in Austin, Texas, and in Austin, we have a culture where we like to keep it weird. It's actually our city's motto. And that means how that translates to being in mainstream medicine is I would have a lot of patient encounters with women that were postpartum and eating their placentas and slathering their babies in essential oils and wanting my advice on what to do next, or not even telling me about it because they were afraid that I didn't know what to do with the information that they were providing. I didn't feel like I could truly collaborate with my patient for what we both wanted, and what we both wanted was the best health outcome for the child. So today I hope you learn a few things, including a few common integrative management of common diagnoses you'll see over and over again in pediatrics, and have an evidence-based approach to evaluating herbal medicines and dietary supplements. And for my disclosures, I do not have any disclosures. I do have some services and tools that I like that I may mention, but I'm not getting any financial reimbursement from any of those institutions or organizations. So, what is integrative medicine anyway? Well, integrative medicine is really taking Western medicine and Eastern medicine, or a holistic medicine, and merging the two. So, instead of being exclusive to one type of practice or the other, it's really a combination of both. So it's a whole body treatment. You use evidence-based methodologies, and our slides are cut off at the end. Do y'all see that? If you would just, maybe we can get some assistance with the AV guys. So I apologize, we were having a little bit of AV issues before. So there's really not one very, very specific definition for integrative medicine. You'll find it in various places saying various things. But the nuts and bolts of it are we're integrating holistic practices and mainstream practices to have the best outcomes of the child, no matter what the name is. So what are natural health products? Well, I like to use this word natural health product because I think it's very encompassing of the things that we use in integrative medicine. A natural health product is anything from vitamins, minerals, homeopathy, herbal medicines, traditional medicines, essential fatty acids, and amino acids. So these are the things that you'll typically find at your vitamin stores that don't require a prescription. But there's a little caveat to that because pharmaceutical industries are getting really, really smart. And a lot of them, you'll see something called medical foods, which you'll have to prescribe, but it's kind of a marketing thing for them. We'll talk about a little later. So the FDA in the United States calls our natural health products dietary supplements. And they do this through law and regulation. So dietary supplements, according to the FDA, and this is on their website, are intended to supplement the food and drink of man. So I don't know about you, but if you've ever used melatonin, I don't really see it as a food. I see it as a regulator of sleep. So there's a lot of nomenclature, but the FDA sticks by calling dietary supplements, and it has a lot to do with regulation, which we'll, again, talk about in a few minutes. So there's a lot of nomenclature in the terminology if you were to Google something, or even look at Scopius or PubMed in the medical databases. You'll see botanicals, dietary supplements, CAM, natural products, natural medicine, traditional medicine, herbal medicine. And know that when you're talking about CAM, it's an umbrella term. So CAM includes dietary supplements. But CAM is complementary and alternative medicine, and it'll also include all kinds of things like Reiki and massage and homeopathy, et cetera, et cetera. Okay, here we go. Why do we care? Why is it significant to our practice as pediatric nurse practitioners? Well, because people are using them. 31% of children are using natural health products, and this is a low estimate to me. This was done by the NHP survey. This data was collected a few years ago. I am under the impression it's even higher, but we know for sure it's higher in adults, up to 50% and higher, and more in chronic illnesses, such as those that have asthma and cancer, etc. And we're spending a lot of money on natural health products. In fact, almost $15 billion in 2007. And what I think is daunting is that is a third of all prescription health cost, a third. So I went to the National Institute of Health and their Office of Dietary Supplement Practicum they give for providers. They choose 100 providers a year, and they do it every year. And Daniel Fabricant was he's the president, and he gave an estimate 2 years ago that there were 85,000 natural health products on the market, and he said that number was growing every day. So that was an estimate 2 years ago, so you can imagine that number's even higher. But in mainstream medicine, how do we deal with this? What's our typical behavior? Well, the literature shows that we have this kind of don't ask, don't tell approach. Don't ask about it, because if your patient gives you information for it, somehow then you're responsible and you don't really know what to do with it. And the patients aren't telling you. Up to 72% of patients aren't disclosing. Up to half of providers aren't asking. But they're not disclosing because they fear that we don't know what to do with the information, and they fear that we're going to judge them. So where do they go? There was a study done by Zhang and Associates, and they looked at where parents were using gripe water for their infants with colic, and where were they getting their health-related information on treating their baby with colic. And what they found was they went to their friends, family, and the internet, and the last person that they asked about it was their healthcare provider. So it's important for us to know, because natural is not always safe. Does anybody know what this plant is? It is the coca bush, and if you ground it up into little white powder and snorted it, it would also be cocaine. So it's a plant, but it also can be an illegal street drug that can have many adverse health consequences. So a lot of providers think in mainstream medicine, and hopefully that this is changing, is, well, where's the randomized double-controlled trial, placebo-controlled trials on natural health products? I mean, there's really no science behind it. But what we do know is there is a lot of science behind it. You just have to know where to look. In fact, in pediatrics alone, and this estimate was given in 2007, there was 1,400 randomized controlled trials and 47 systematic reviews looking at CAM in pediatrics that were as good or exceeded those in mainstream medicine. And now something exciting is happening with the Consortium of Academic Health Centers on Integrative Medicine. It's a cohort of institutions that are coming together for research and dissemination of natural health product and integrative medicine research. And some of the big players, Harvard is involved, and Georgetown. So there's some big players that are looking at, this is an important topic for medicine. This is an important topic for us. And we want to practice evidence-based medicine. Let's come together and continue to do research and publish. So you're right when you're in that patient room and the infant, in my experience, is, crying, fever, and the parent is looking at you like, don't you dare prescribe me antibiotics. I'm going to use my essential oils from whichever company that they're using. I don't know about essential oils, or I didn't when I first started. And I just knew that what my mainstream treatment of this infant should be. So I was skeptical. I should have been skeptical because I didn't know. But with each situation that you don't know, you should have skepticism and belief when you approach it. You can't discount because someone is engaging in a healthcare behavior that you've never been taught about, that it's quackery or there's no science behind it. So let's just talk about a couple of common applications in pediatrics. First is iron deficiency anemia, and we should all know this in this room. We're going to talk about some very, very common things that we see. So it's common, very common in infants, very common in small children. It's the most single nutrient deficiency that we see. It's the leading cause of poisoning under 6 years old. And iron comes in two forms. It's heme, which are from animal sources, and non-heme, which are from plant sources. And we need heme for our bone marrows to produce hemoglobin. So who's at risk for iron deficiency anemia? Well, the prematurity, those that have poor diet, poor growth, that are of Hispanic population and poverty, that have lots of light exposure, that are exclusively breastfed, and have a lot of blood loss, of course. So iron deficiency anemia can lead also to an increased absorption in lead. It's because they compete for the same sites. So what does the AAP recommend for iron deficiency anemia? Well, if you're exclusively breastfed or more than half of breast milk, you need to start your infants on 1 milligram per kilogram of iron at 4 months until they start iron-fortified cereals. And this is really important because there are a lot of new moms that don't want to feed their children grains or cereals. So if you're premature, the rules are even a little different. You need to start supplementing with 2 milligrams per kilogram of iron from 1 to 12 months if you're exclusively breastfed. So even though these little premature infants are being supplemented, still about 14% of them become iron deficient. Testing, everybody should be universally testing for iron deficiency anemia at 12 months. And if a hemoglobin is less than 11, you're considered deficient. The National Institute of Health has some really great guidelines on recommended daily allowances. They are the Office of Dietary Supplements. It's a free source for providers. You can Google it and get the RDAs for many, many nutrients. So here is it for iron in infants. This is just important to have always. So allopathic means mainstream. So here's our mainstream treatment of iron deficiency anemia. Well, go by the guidelines for prevention. That's common sense. We need to replace the iron. And then if you're replacing iron and your hemoglobin isn't rising 1 gram after 4 weeks, then you need to really discover and think about other differential diagnoses for anemia. So more of a workup could be applicable, but the most common iron deficiency, or the most common type of anemia, is iron deficiency anemia. So what's an integrative therapy? What's a non-mainstream recommendation? Well, first, when you're recommending iron, did you know that there are many types of iron? We're supposed to be giving elemental iron, so the elemental weight of iron. But all iron isn't created equally. There's ferrous fulmarate, which contains 33% of elemental iron. There's sulfate and gluconate. So you always need to look at the form of iron you're recommending for your infants. And then you tell parents to avoid drinking milk or dairy products around it, and vitamin C or citrus. Juice helps increase the absorption of it. The American College of Obstetrics and Gynecology came out with the consensus that for premature infants, delaying cord clamping can help mediate the effects of iron deficiency anemia in premature infants. Now, for those that are term, the evidence isn't as supporting for that. So another thing you can do is iron-rich foods, so cast iron cookware. I had a patient last week that her hemoglobin was off the chart. Well, not off the chart, but it was pretty high. And we were trying to think of other forms where she might be getting iron. And she cooks with all iron cookware. I mean, all of it. So iron cookware can be helpful to get extra sources of iron in your kids, but I wouldn't recommend having everything you ever cook on be cast iron cookware. And also liver extract. You can actually ingest liver extract, and it helps increase the red blood cell counts. I've never had any experience with injection of it, but apparently it has the same effect. And another thing that is really, really exciting, and it's beyond the scope of this talk, but is genetics. We are now understanding some things called genetic polymorphisms or methylation SNPs and how we can assimilate nutrients. And so those that are persistently iron deficiently anemic, you might want to look at an MTHFR genetic polymorphism on them, which could mean that they're low in B12 or folic acid, which can then affect their hemoglobin levels. All right, moving on to URIs. So we know the average person gets about 50 colds in their lifetime, and then, of course, it is greater in childhood. It's the leading cause of why we miss work and school, and we spend about $3 billion on over-the-counter medicines for this. So we spend a lot of money treating this over-the-counter, and it's a very common occurrence in all of us. And I do not know what the rest of my slide said, so I'm going on. So allopathic treatment, again, what we do in mainstream medicine, we give fever or pain reducers if they're indicated, nasal decongestants, Mucinex if it's indicated, cough and cold medications if they're indicated and they're old enough, and then we look out for secondary infections. For integrative therapies, echinacea, and this is commonly confused in my patient population, when to give echinacea and when to give vitamin C. So I think this is an important take-home message. Echinacea is for prevention of colds. They do not treat colds or shorten the duration of symptoms once you have a cold. And prevention looks like 500 to 1,000 milligrams 3 times a day for 2 to 3 weeks in adults, or 100 milligrams every day for greater than 6. In my practice, if somebody starts getting a cold, I might recommend, hey, for prevention, you might want to just take some echinacea until the cold is out of your home. Sage and echinacea, it's interesting. You can actually do mouthwater sprays and gargles to help with the sore throat. It helps decrease inflammation. I don't see a lot of products over the counter for this. It's not as common as you'll find with echinacea. And then, of course, there's vitamin C. I think somebody gave a lecture earlier today, vitamin Z for Zithromax. Anyway, vitamin C, it is a water-soluble vitamin, and it can help reduce the duration of a cold. So 200 milligrams or greater at the onset of symptoms for the first 3 to 5 days of illness or longer. But we got to be careful. As in any natural health product you recommend, you always need to be looking for what are drug-herb interactions, what could be a toxicity of it, what are the things around this that I need to know. And with vitamin C, greater than 3 grams a day will cause diarrhea and increases your risk for kidney stones. Emergency is a pretty big one that people like to go to when they're feeling bad. They just go get a bunch of Emergency. I had a patient tell me that they took 1 Emergency every 2 hours until they got diarrhea and it cured their cold. Which, I'm sorry for that person's gut because I wonder what inflammation that was causing in the gut. But also, this patient had fever at the same time, and they didn't want to take ibuprofen, so they took Tylenol. And Tylenol competes for the cytochrome P450 pathway that also vitamin C is excreted through. So actually, if you take them together, you can increase hepatotoxicity because you're not excreting the Tylenol even at standard doses. So no Tylenol and vitamin C together. Another integrative therapy for upper respiratory infections is zinc. It's an essential trace mineral. Zinc it has so many important properties in it. But for URIs, it really helps support the healthy immune system. You'll find it a lot in lozenges, which are great for kids because it's like they're getting a little piece of candy. Of course, I prefer them with no high fructose corn syrup or dyes in them as well if you find one. Usually you find lozenges in about 5 to 10 milligram per lozenge. But you give it at the onset of the cold symptoms, and then you give it until the symptoms are over, so 3 to 5 days. And this is one of my favorite things to prescribe or recommend. So elderberry is a fantastic alternative for Tamiflu, or the flu medications. It has the same mechanism of action as Tamiflu. It works as an antiviral. It significantly shortens the duration of flu symptoms and enhances your antibody resistance against the influenza virus. Now, this study, and it's referenced on the bottom, they did 15 milliliters 4 times a day for 5 days. But now the same thing, it's by Sam Bukal. You'll find them a lot over the counter. They've condensed their milligrams, so now it's 10 milligrams, 10 milliliters, not milligrams. So 2 teaspoons rather than 3. So if you see a discrepancy, if you looked up the literature, that's the reason for that. So the thing about elderberry you have to be careful in is you'll find a lot of products on the market, and they're marketed for really, really, really young children. And the studies really don't support it other than greater than 12 years old. So what I do when my patients come in and they've already done half a bottle of elderberry for their 2-year-old, I'll just say, well, you really should proceed with caution because the studies really aren't very strong and they don't support it under 12. But you'll find products all over the market that start using elderberry at 2 years old. So the contradiction with this is just don't give it with immunosuppressant agents because they're counterintuitive. And there have been no known side effects reported for elderberry, which is hard to believe. But I haven't found any. Okay, on to diarrhea. So about 100 million cases a year annually. Children less than 5, they have about an average case of once a year. And you know the etiology: viral, bacterial, parasitic, food intolerance, allergies, artificial sweeteners, believe it or not, and of course medications. So how do we get it? Droplet contact food contamination is some of the transmission modalities. And your symptoms, your bloating, your watery stools, your frequent gas and abdominal pain, and sometimes fever. So how do we treat it? Well, hydration is always important. Antidiarrheals have typically been given in the past, and depending on the etiology of the diarrhea, you may consider antibiotics. I love probiotics. I am so happy that we understand, and probiotics are just continuing the data out there, and the implications for them are just so incredibly widespread. But in diarrhea specifically, the evidence is very, very clear. You can give probiotics for diarrhea. Saccharomyces boulardii and Lactobacillus GG have been the 2 strains that have been most. I'm okay, thank you. They're the ones that have been most studied. What I recommend is once you start getting diarrhea, you start with the probiotics. Cultural for Kids is one over the counter that's very good. It's Lactobacillus GG. And you can start it twice to 3 times a day for 7 to 10 days. So remember, when your patients have diarrhea, they're getting rid of some of that great gut flora. You're putting a probiotic in, which is good, healthy bacteria for their gut. It helps balance the gut. But then you want to continue to recolonize the gut after the bacteria or the bouts of diarrhea are gone. You never want to give probiotics with antibiotics because they're counterintuitive. One's taking away the bacteria and one is replacing it. So I always recommend separating them by about 2 hours. So with ear infections especially, if I put a kiddo on an antibiotic, I'll say, we really need to think about going on some probiotics too, but this is how we're going to do it. We need to separate them so you're not giving them together. And then you see greater compliance towards antibiotic therapy and less side effects because you're healing the gut as you're taking away some of that good gut bacteria. So you want to be cautious with probiotics with autoimmune or immune dysfunction patients, people that are, on chemotherapy, or teeny tiny infants, because we don't want to give them too much bacteria and cause septicemia. Another implication for diarrhea is zinc. So zinc will actually shorten the duration and severity of diarrhea. You give a little bit more for somebody that has zinc, 20 milligrams of elemental zinc once a day during the illness. And you can do this for infants 6 months and greater. All right, is anybody sick of hearing about vitamin D? We hear about it all the time. We all know 400 units from birth, exclusively breastfed infants. You better have them on their vitamin D. But there's so much more to vitamin D than just trying to combat deficiency in infants that are exclusively breastfed. Vitamin D is really not a vitamin. It's a hormone. Because it acts like a hormone, it doesn't act like a vitamin. Vitamins regulate cellular enzymatic activity. Hormones bind to cells and regulate their function. Vitamin D, you should know about 2 things. Which type? D2 comes from plants, and it's a non-active form, so we don't measure it. We don't look at it. We look at D3, which is what we are synthesizing with our human skin when we're exposed to sunlight. Those that are at risk for deficiency are breastfed infants, people with dark skin, because that's their natural sunscreen that they're wearing all the time, people with Crohn's disease because they have gut dysfunction and their absorption rates are lower, celiac disease falls in that same category, and obesity because vitamin D is fat soluble. So why are we so vitamin D deficient? It is very multifactorial. We're deficient because we're not taking in enough. We're more indoors. Our kidneys aren't able to take it to its active form. We have limited gut absorption. And now another exciting thing that we're finding with genetics is there's actually something called a VDR genetic polymorphism, which on the vitamin D receptor sites, you may not be able to methylate that vitamin into your cell or that hormone into your cell. So genetics can play a big role in vitamin D deficiency as well. And here are the symptoms. Most likely there are no symptoms. I cannot tell you how many patients that I have tested that they are way below where they need to be and they're completely asymptomatic. We did it at a well check. Other symptoms that you can have is immune dysfunction. Unless you're at 50 nanomoles per liter, you don't even have immune protection from having a vitamin D level. Other symptoms are endocrine dysfunction, cognitive impairments, and I bet you could find much, much, much more in the literature. The applications for health just get stretched broader and broader all the time. So the AAP says 400 international units for those breastfed infants when they're born, and then when you're 1 to 70, it's 600 international units. I predict that this will change, and I really encourage you to guide your therapy based on your patient and their level, not on these recommendations, because we need to be from 50 to 75 nanomoles per liter to have a healthy vitamin D level. In my neck of the woods, we use a lot of clinical path laboratories. It's our major lab in Quest, and our range for vitamin D is 30 to 100. 30 is deficient. Less than 50 is deficient. There is a lot of good data to support this. So if you put somebody on vitamin D, the research suggests for an adult you have to do at least 1,000 units, but up to 10,000 units. And because it's a hormone and you can reach toxicity, you need to be rechecking it. So put a kid on some vitamin D, depending on what their level and their age is and their barriers. If it's a darker kid, I'm going to put him on more because I know it's harder for him to absorb it on his own. And then I'm going to check him, and they say every 4 to 12 weeks. I check my patients at 4 to 12 weeks. I check my patients at 3 months because I've never seen a level fix itself until about 6 months. So what are the side effects of vitamin D? You just have to make sure you don't get to toxic levels. So greater than 100 nanomoles per liter, don't go there. I would stay at 80. So having your maintenance dose is going to be completely dependent on the person. If you're toxic, you're going to have nausea, anorexia, heart rhythms, etc. So interactions with vitamin D, if you look for interactions, there are multiple. And I encourage you with your patients, if you're on mainstream medications and natural health products, that you should always be checking for interactions. The literature lists many. I haven't seen any that have been applicable in my practice as of yet. I get this question all the time. Well, can't we just go play outside some more? I wish that was the case. And in the perfect storm, you could. The perfect storm meaning you have to have the right kind of light, which means the right wavelength of light. You need UVB radiation, 290 to 320 nanometers. I don't have a nanometer finding at my house, so I don't know. And you need the right kind of time. You have to be outside approximately 5 to 30 minutes between the hours of 10 and 3, the right time of year, without sunscreen and most of your clothes off to get enough vitamin C. So the conditions have to just be perfect. So really the answer is likely no. Is sun enough? All right, let's talk about insomnia. So insomnia is when you can't sleep, or you can't fall asleep, or you wake up after you're asleep. In our traditional allopathic therapy for insomnia, we give benzos, non-benzos, over-the-counter sleep aids, antidepressants, and parents love to give Benadryl. And it's those parents that gave Benadryl for the first time to get their kids to sleep, that they were up all night, that they come back and they're like, I don't understand what happened to Benadryl. Because you can have that paradoxic effect. Some people get stimulated from Benadryl because we're all unique and our genes are not all the same. So for sleep onset insomnia, the literature very highly supports melatonin. So melatonin is a neurohormone produced by the pineal gland. The studies have shown that from 2 to 6 milligrams, 20 to 30 minutes prior to sleep, ages 6 and above. So those parents that are trying to sleep train their infants that are 2, no melatonin for them. So really 6 and above is what the literature supports. Side effects are dizziness, sleep maintenance, insomnia, headaches, nausea, skin changes, and nightmares. I find those that are taking very high doses of melatonin on their own without my guidance are the ones that suffer from nightmares. So interactions, again, you need to be checking for interactions with melatonin. There are a lot of them. So short-term therapy for melatonin has the strongest evidence, which means you just can't give your kid melatonin every night for their entire life because you're ready for them to go to bed. Really 2 to 3 weeks to really help them reset their rhythm, and then you wean them off of it. I find that 1 milligram usually does the trick. All right, attention deficit hyperactivity disorder. We don't now call it ADD, it's all ADHD. I really enjoyed Dr. Moldenhaar's presentation on integrative psychiatry. If you guys didn't get a chance to see it, I highly recommend you get the notes. She did a fantastic job. So she didn't touch on ADHD. I'm happy to do it. We know that ADHD is ubiquitous. It's everywhere. It's common. 11% of children, 4 to 17, some people are trying to diagnose them earlier. And this is increasing every year. And what is the etiology? It's multifactorial. It's environment. It's nutrition. And it's genetics. The symptoms, you've all heard them: inattention, impulsive behavior, etc., can't find my shoes. And the testing, parent-teacher questionnaires, and now there's some more objective testing with EEG technology. It's not conclusive. You can't do an EEG test and say, absolutely, this kiddo has ADHD. You're still using the parent-teacher questionnaires and coming into just a consensus with everything. So the allopathic treatment is stimulant medications or non-stimulant psychotropics. And for integrative therapies for ADHD, the evidence really supports that the number one thing these kiddos are deficient is in omega-3 fatty acids. So omega-3, all omega-3s are not created equally, or all fish oils are not created equally over the counter. For ADHD, for treating ADHD, you really want to look at the ratio between EPA and DHA. So EPA needs to be much higher than the DHA ratio. DHA is great for brain maturation and growth, but not for treating inattention symptoms. We also find that these kids are extremely deficient in zinc, vitamin B6, and magnesium. Now, vitamin B6 and magnesium and zinc, we really have to go back to, I can't say this without saying that there's a lot of implications for genetic testing here. So I don't know if anybody has incorporated pharmacogenetic testings into their practice yet, but that is one of the best things to guide therapy. And you're also looking at some genes that can lead to mutations in how you're assimilating nutrients and breaking them down. MTHFR that we mentioned before is just one of the genetic SNPs that people really know about, but there are many, many more that have implications with ADHD and cognitive health. For instance, the COMT, genetic polymorphism. But again, I digress. That's beyond the scope of this talk. So other integrative therapies for ADHD, now there's doing a lot of brain training, brain balancing. Some computer-based training have some efficacy, and I think that if the parents are really, really willing to do whatever it takes, change nutrition, go on supplementation, get into some of these play attention, cogmed things, it can be pretty costly, so it has to be dependent on the patient and the motivation of the parent to really follow through. Okay, so those are the common things that you'll see over and over and over again in your practice. I want to leave you with some principles, or not leave you yet. I'm not leaving you yet. But I want to talk about some principles of just as a clinician, no matter what the diagnosis is, if you want to try to incorporate using integrative medicine and natural health products into your practice, things that you need to think about. So first, you need to ask. So we know we're not asking because we don't want to know the answer, but you got to ask. You got to ask what they're on. Next, you need to have knowledge about natural health products. There, I'm going to give you some sites and information on some really awesome clinical tools that you can use to have quick knowledge, just like Hippocrates. And then you need to be able to direct your patients on what are reliable sources of natural health products. They're not all created equally. And then you always need to look for potential drug-herb interactions. For instance, the vitamin C and the Tylenol. Who knew? You should not give those together. And then you always need to recognize that you will have limitations, and you need to refer or defer as it is appropriate. And also, if you put somebody on a natural health product, you should monitor the response. So if I'm going to put a kiddo with severe ADHD on a bunch of supplements, I'm going to see them a little bit sooner. I'm going to monitor the progress of them. I'm going to really understand, what are their zinc levels, how much are they taking, what's the compliance, what's the efficacy, and you follow up as appropriately. So these are wonderful, wonderful databases. If you were to get one database to practice integrated health, I would recommend Natural Standard. Now, they just merged with Natural Medicine's Comprehensive Database, so I think it's Natural Database now, but if you Google Natural Standard, you'll get it. And I didn't change my slides because we turned them in quite a while ago. So they've merged, but this is by far the best database. It'll give you mainstream treatments, it'll give you allopathic treatments, complementary treatments, integrative treatments. It is really kind of a one-stop go-to source, and I think a prescription for a year is about $100. Also, the National Center for Complementary and Alternative Medicine is a great free source that you can go to, and the National Institute of Health Office for Dietary Supplements. You'll find a lot of good information there. And for CEUs and for site-based learning, I came to find out today that there's actually some DNP programs now. There's 2 in the country that they're doing on integrative health. So there's one in Minnesota, and then there's one in another part of the country. But this is emerging, and if you're interested in it, I really feel like we're on the forefront of a lot of changes in medicine with integrative medicine. So the Ohio State Wexner Medical Center, one of my mentors is there. She's the chair for the American Academy of Pediatrics for their Integrative Health Division. She's wonderful, and she runs that. They do a lot of site-based learning or online learning. So when I mentioned before that natural health products are not all created equal, it's because they're not. We have to be careful because there's a lot of because of the way that they're regulated in the United States, that they can be contaminated. They can contain things that we didn't expect, metals and pesticides and even other prescription medications. Serving sizes on the bottle can be ambiguous or missing completely. And then the numerous ingredients. If I find a product and I look in the back, unless it's a multivitamin, multimineral, and I see more than 5 to 10 ingredients, I'm not going to buy the product. Because how can you really look at the synergism and the combinations between every single nutrient together? You have to be careful. The fewer the products, the absolute better. So in the United States, we had something called the Good Manufacturing Practice Law come up in 2007. And this was supposed to tighten the regulation on food products or dietary supplements in the United States. So this is what they wanted to, they have guidelines for people that are making supplements for their purity, potency. They have all these major regulations that they're supposed to adhere to in order to produce a supplement. But here's the key. You can say that you're GMP compliant and nobody's ever checked on you. So you have to look for third-party product certification. And that's not the slide next, so we'll go to the next one. So on the label too, dietary supplements, you cannot say that you're going to treat an illness. You cannot. It's not intended to treat, cure, et cetera, the slide before, and that's FDA regulation. You'll see that on every single supplement bottle. They have to put that. And you'll also see that on a lot of integrative health websites. They'll put that FDA disclaimer at the bottom as well. There it is. And the reason that the FDA does this is because not that they're trying to one down the supplement manufacturers, it's because they're really wanting you to say, hey, if you're trying this and it's not working, you need to go see your mainstream medical provider or somebody else that can provide you care. Because we, as citizens of the United States, can go and buy our supplements without a prescription, and this is our right. But you can be doing this to an end that's not efficacious in treating for what you're needing to be treated. So this is part of the FDA's rulings. So here are those third-party product certifications. It is the National Sanitation Foundation, one of my absolute favorites, the U.S. Pharmacopoeia. You'll see Consumer Lab does a lot of off-the-shelf testing. And here's your GMP, but notice it's GMP certified. So there's that third party. Somebody came into that supplement place, made sure that they were compliant with the GMPs, and then they stamped their certification. Here we go. There's a safety reporting portal that you should know about. I've never used this because I've never had an opportunity to, but the National Institute of Health and the FDA merged and say, okay, if you have any adverse reporting of natural health products that your patients are on, please report them so we can know, so we can build our database for things that are having adverse effects. And they'll use this for companies that are having a product, they're having adverse effects, so they can go and pull it off the shelf if need be. And one other thing that is interesting about integrative medicine, if you start practicing integrative medicine and you really start prescribing supplements, you really start wanting to use essential fatty acids and other amino acids in your practice, you can do it a couple of ways. So you can have supplements that you sell out of your office, which for a lot of people that's not feasible. We practice with other people. We don't want to deal with putting them on the shelves and dispensing them ourselves. You should know that this is how the supplement industry works. If you're a provider, you get 50% off all of your supplements if you have a account with that supplement manufacturer. So if you buy vitamin D at $10, you can sell it for retail to your patients at $10. This is what the pharmacies do. This is all, if you are pharmaceutical grade supplements, this is what they're all doing. There's also some other things that you can do at provider dispensary where they manufacture or they hold all the supplements for you, and you can send virtual prescriptions to your patients, and you can pick and choose what you want, and then you can either get your commission that way if you want it, or you can give your discount 100% to your patients. As with anything, and I think this goes without saying, but I'm going to say it, you just have to be careful about conflict of interest. You don't want to put your patients on a list of supplements because you're going to get a kickback for them. But on the other hand, paying for your time and expertise and ensuring that they're on the good products that you want them to be, I don't see a problem with that. So you may disagree with me, but I think that in this age of integrative medicine and trying to survive as providers, especially for us that have our own practices, having things that can generate income in an ethical and health modality treatment we're really looking at patient outcomes, I don't see a problem with it. So in summary, I don't know if I went fast or not. Maybe a little. So in summary, there's compelling evidence that we should be integrating natural health products and using integrative medicine. There are so many indications for it. We went over several today, and there's more and more and more and more. So we have to, when we practice integrative medicine, be careful about the pharmacovigilance in the United States of how our supplements are made and what we recommend. And we should also make sure that we're infusing those principles of decision-making into when we're providing care. We got to know what we're saying. We got to ask the questions what our patients are on. We got to know some common things. And we got to partner with our patients and follow up on them so we can ensure that they have good health outcomes. So that's it, and I'm happy to take any questions. Yes.
First one here. Okay, I just have two questions. One, with all those seals of approval, is one seal, that the first one you mentioned, is one better than the other? If you look at the bottle and you said, oh, this was certified by
for like the pharmaceutical grade ones, they have multiple seals of approval. Most of them do. But if you just have one of those good seals, I would feel confident with the product.
Okay, great. And my other question was, with all of the different dosaging, you said all of the dosaging was based for greater than 12 years old, except the zinc for 6 months?
So just with the elderberry.
Just the elderberry.
Just
okay.
the elderberry. There was some that were greater than 6 years old. Okay. So greater than 12, I just think was in the elderberry.
Okay, so then younger kids can do zinc and vitamin C and...
Oh, absolutely. And there's... with zinc, there's also different ways to look at functional deficiencies, and this is getting kind of a little bit more specific, but There are tests that instead of checking for serum zinc levels, you can do functional nutrient testing. So I do a lot of zinc. Zinc is a cofactor in many metabolic processes, especially in making of serotonin and dopamine. And it is shocking how many people are deficient in zinc.
Thank you.
Okay. Okay, so the question was, what age do I feel comfortable prescribing probiotics? And from the get-go. Absolutely from the get-go. I believe a lot of even formulas are putting probiotics into their formulas. Now remember, if you're a teeny tiny neonate, premature, have multiple health conditions, you have to be very, very careful. And for health maintenance for probiotics, I really like a multi-strain probiotic. I know that for antibiotic-associated diarrhea, we talked about the lactobacillus and the Saccharomyces, but I really like a multi-strain for health maintenance.
What is the dosage that you're recommending for magnesium and vitamin B6 supplementation for ADHD, as well as the omega-3s?
That's a great question. So magnesium, it depends on the kiddo. And remember, magnesium, there's multiple forms of magnesium. So magnesium citrate is going to tear your gut up if you have too much of it. You want to go with magnesium glycinate is a better form. It's easier on the gut, or magnesium stearate. And for kiddos, like a 6-year-old kid, I might put him on 50 to 100 milligrams of magnesium at night. Magnesium tends to have a neurocalming effect. And B6 is kind of a tricky one. Some people, it depends on your methylation and your genetics if you're checking them on your CBS SNP, but some people can really tolerate just a little bit of B6. So just a few milligrams of B6. And was there another one for the zinc? For the omega-3 fatty acids. So getting above, like in a 6-year-old, getting above 1,000 milligrams, and really the ratio, you want about a 7 to 10 to 1 ratio, so 7 to 1 or 10 to 1. But if you get above 1,000 milligrams, you got to just kind of be careful about anticoagulant effects on platelets, and you kind of get a runny tummy if you get over 1,000 milligrams. There is a company out there called Viren. Have any of you prescribed it? Yeah, Viren, so this is the tricky thing about medical foods again. So Viren is indicated for ADHD, or they market it for that. And for older people, they have Viacog as well. And Viren is basically krill oil. It's EPA and DHA, but the ratio is so, so small. They put Viren with a little phosphatidylserine on it, which is a phospholipid, and their claim is it helps penetrate the blood-brain barrier a little bit more. But the amount of EPA and DHA is so super, super small in it. And if you prescribe it to your patients, it is about $80 a month. So I really feel like you can go out and get a good omega-3 fatty acid. And I like Nordic Naturals. They do fish oil really well. You can get the high EPA formula for them. And if your kiddos can't swallow pills yet, you can snip off the end and squeeze it into something that, like a scoop of whatever is delicious for them, and try to hide the taste. Or they also have some ones that pop in your mouth, or they also have a liquid. It's a great question. She wants to know my thoughts on essential oils. I have so many people that use essential oils. It's one of the things that got me started into this, and they were just, I'm using thieves oil for this, and I'm using this oil for this, and they're diffusing in their house. And the answer is I don't know a lot about essential oils. I think it's transdermal absorption mostly for essential oils. You got to be careful about the potency of it and and I don't know how to regulate the dosage on it. And there's not a lot of evidence-based literature that I can recommend off of that. But I have to tell you anecdotally, people love them, and I mean they love them. I don't know if it's placebo. And I don't know if it's medicinal. I just don't know enough about essential oils. Yes?
Is there a good database you could recommend to look up drug interactions
Yeah,
with herbal medicines?
Yep, Natural Standard has a drug interaction. They have a drug herb checker and an herb checker too. Okay, so the question was, can you comment on BioGaia drops for infants? And I don't know the ingredients in it. I know Gaia Herbs is a good supplement company. She does a lot of herbal products, and they are third-party tested and regulated, and I would consider them a pharmaceutical-grade medicine. I don't know. Probably for colic, and a lot of things use digestive enzymes, so it must possibly could be digestive enzymes, like Coles. They're here at the conference. It's just a digestive enzyme in there that they're using. And then there's also at the conference, there's the VSL, which is a probiotic, which they are getting smart too, because half of their, or 3/4 of their products you can get over the counter, and then one of them you write as a prescription. But only because it's a marketing tool, not because they can't put it over the counter as over the counter. Yes. Oh, I'm sorry.
Just a quick question on the vitamin C. What would be a max dose for a child?
So it depends on their age. I wouldn't go over 1,000 milligrams. And if you were to do, say, a 3-year-old and put them on some vitamin C, I'd probably start off with 250 twice a day. But you don't want to go over 1,000 milligrams because then you just get an upset tummy and diarrhea. And it's a water-soluble vitamin, so people feel very comfortable giving lots and lots and lots of vitamin C. I just don't see the efficacy in it, and you get a lot of side effects.
Thanks.
Yes, I had a question. It was similar on the ADHD piece.
Yes.
I work in a school setting, and I'm on many IEPs, and where parents are, this is being discussed.
Yes.
And I'm wondering, do you have some article references that would be kind of a good balanced discussion on this issue? You've mentioned several pieces of, like the zinc and the vitamin B and the 6 and the magnesium.
Yes, I do. And on my reference list, you'll find an article to support every single choice that I've made on there for zinc and omega-3 fatty acids and B6. I think the one thing that I'm going to go back to this again is really looking at how we're methylating our vitamins. So a lot of these kids that have these genetic polymorphisms, the MTHFR, the COMTs, I know I must be speaking Chinese to most of you because this is just new and emerging. A lot of these kids are deficient in their B vitamins. So if you're giving somebody a B vitamin and you have this genetic SNP to where you can't break it down and put it into the cell, you can give them B12 all day long, but it will never assimilate into the cell. You have to give them the methylated form of those vitamins. So we're seeing a lot of kids now in my practice, I'll do genetic testing on them, and they have a lot of these genetic SNPs. And if you back up and really start addressing methylation, you really start addressing the attention and neurocognitive things that they could be suffering from. I think Dr. Moldenhauer today did a really good job of explaining some of that.
Thank you.
Any other takers?
Hi.
Hi.
I don't know how, what is the standard of practice for iron supplementation with 4-month-olds? We typically put kids on polyvisol just because that's just what we do. And then parents will come back to the office 2 months later, parents that are exclusively breastfeeding their babies, and say, they hate it. They don't tolerate it. And even after talking to them about how, the importance of it, they're like, they're not going to do it. They're not going to comply. Mm-hmm. What are the alternatives?
Well, first of all, congratulations for putting your 4-month-old on iron if they're 4 months old and exclusively breastfeeding, because I can tell you the compliance to that regulation or that policy statement is very low. And polyvisol iron is a metal. It all tastes horrible. And these poor infants, they need it. I don't know any other preparations that taste any better than polyvisol at this point. Certainly the mom can eat more iron-enriched foods. Certainly you can mix it in something to see if the baby has a taste, or you can do a hemoglobin and show her some objective evidence that this baby still needs iron. So a lot of times with my patients, I'll do that. And then you have to talk about, the developmental sequela that happens from being deficient in iron. It's needed for growth and development for so many processes, for heme, et cetera, et cetera. So moms will say to me, well, I eat a lot of iron-rich foods. you really can't pass enough down, nor can you pass enough vitamin D down. For moms taking vitamin D, you have to take nearly toxic doses to pass it down enough to your infants. Does that help?
Hi, Emily.
Hi.
I'd like to make a comment about nasty tasting iron. Did anybody see the Novaferrum guy? Dude, it tastes good. So,
There you go.
And it's in the state of Texas. It's on the Medicaid formulary, but they're down there in the exhibit hall. And it's not ferrous sulfate. It's another form. I think it's the more bioavailable form. I guess you missed it because you were manning our special interest group on integrative health table.
Oh, yes, okay.
You might want to give a shout out to that.
Yeah. So for the special interest group, we have just formed our special interest group on integrative health, and monthly we're going to send out emails on things like iron and vitamin D and provider dispensaries and tools and questions on genetics and pharmacogenetic testing, which I really hope next year we have a lot on genetics. It's so exciting. So come join our SIG. Tomorrow we're having a meeting from 1 to 2, and we're just going to talk about, what topics do you want to hear more about this year? But I really wanted it to be a place for support for people that want to incorporate integrative medicine into their practice, because it's a big learning curve for being in mainstream medicine. We're not taught this in school, and I loved my school. I loved it. The University of Texas at Austin with my master's was amazing, but I wasn't prepared. I was not prepared for my clientele, for Austin. And my take is we need to get prepared for what our patients want, and I think across the country, more people are looking at integrative health. And that's it. Thank you for attending.